talking about the spine, sacrum to mid-thorax. Knowing the epidemiology of certain conditions is essential to your clinical reasoning, particularly when you're looking at low back pain. I test for the most likely cause, the most likely scenario, and if there's no response, then I test for the next most likely cause. Low back pain is a huge problem in our society. If the patient's not a senior, has had the problem off and on for some years, and gets worse while stooping or sitting, the pathophysiology is likely due to increased pressure within the end plate. That's where the disc and vertebra join. The end plate is really the enthesis of the disc joint to the enthesis of the disc is the joints to the vertebral body. The tests used here increase the pressure at the end plate to even a greater pressure to allow the fluid to move out. We're going to be talking about doing this procedure side gliding with the lumbar spine, somewhat in flexion. We'll do it with extension, and we'll talk about some home exercises a little later on. Now, if the pain worsens with exercise, edema with the intervertebral foramen may exist, or maybe the encephalopathy, or maybe an encephalopathy exists at the small muscles of the back. For those procedures, we'll talk about traction in the intervertebral foramen itself, maybe some segmental loading as per the patient's response, and maybe mention why it's probably not the QL. 60% of the time, 60 to 65% of the time, somebody middle-aged or younger pain gets worse when they sit, is probably discogenic low back pain, which means it's likely pressure in the end plate is too great, so the blood supply can't get to the end plate. So I want to squeeze the pressure in the end plate to even a greater degree that it squeezes the fluid out, and then the resultant pressure is less, blood flow is restored. So I'm going to squeeze the vertebra. Do I know specifically which one? Well, I'm squeezing the lumbar, it's the lower lumbars. Okay, cross your arms like this. Lift your head up now, and just relax. The belt's right across the PSIS, so she's stable, and that's squeezing the vertebra on my side. Okay, now let's try that on the other side. Normally I do both ways. Normally one side moves to a greater degree, and that's normal. That doesn't mean they got a problem. We're really not symmetrical. Symmetry is used, I know, as an indicator for care, but it's been my experience that symmetry sometimes, asymmetry sometimes can be used, but sometimes not. Head up now, head back and relax and let yourself go. Okay. So what kind of range, are you okay with that? Just like the straight leg raise test I showed you in the beginning, we always start very gentle. We're going to do it again. Give me a response. I encourage the patients. Are you okay? Talk to me. Okay, can I do it again? Can I go a little harder this time? Yep. Head up. And I try and look at them while I'm doing it. You're fine. And I feel, can I go a little further? Yep. I just hold that. As I'm holding that, that's squeezing the fluid out. Normally, if this is successful, I find the range of motion increases dramatically after 1 or 2 times. Now, I'm not comparing the left to the right side. I'm comparing the left to the left, and then the right to the right. That's one way to do that. Now, there's another way to load the end plate as well, but we're not going to, since I have this patient in this condition, we're going to move to a different procedure now. And sometimes people can have a sciatica with no disc problem at all. What they have is they have some edema or something going on in the intervertebral foramen. Now, the intervertebral foramen, if we stretch the structures in the intervertebral foramen, that's going to cause this edema to move out. So it's a similar procedure, except they put more flexion and traction. Okay? Head up now. Okay, quite a bit of flexion. And in this area, I really pull. Feel it stretching in there? Yeah. I really pull. When I drive that way with my legs, I really pull. Can I do that again? Yeah. The tip off with this is they get the warming sensation in the buttock or down their leg. Very close to an end plate procedure, but we're working with the intervertebral foramen. You got to realize in a cubic inch of volume in the low back, there's a lot of things in there. There's nerves that are in there, the venous blood flow, or the venous blood's in there. You have the arterial blood in there. You have the fat in there. You have the ligaments in there, joint capsules in there, enthesises are in there. Now, the low back might be due to perhaps, the spinal nerve root comes out. You have the primary ventral and primary dorsal branch. The dorsal branch of the spinal goes back into the supply the muscles in the joints, the facet joints of the back. Her pain might be from an enthesis in the small muscles in the back. So specifically, I can segmentally load one of those muscles. So I'm going to twist you now, and you tell me when I reproduce your pain in there. Okay? So I might have to give her up, twist a little bit, or I might go this way, maybe a little. Oh, that's it right there, she says. Oh, that's it. So, or I can move the belt up. So I can segmentally load and feel as I lift her or flex her to a certain amount, rotate her a certain amount, and laterally flex her a certain amount. It's going to focus on different vertebrae that I'm interested in. So we went through the end plate, we went through intervertebral foramen, and we went through the segmental. Now it's interesting, when I do this procedure, and I'm loading the end plate, it looks very similar to a QL stretch. The reason why so much time is spent on the QL is because the QL stretch is so effective. And in my opinion, it's really not the QL at all. They're working on the end plate, they're just thinking it's a QL. Now the last procedure is to show you how to load the end plate. Let's have you lying on your tummy now. Slide back a bit more. This is Mackenzie, extension of the line. This is Robin Mackenzie. I thank Robin Mackenzie. He let me take his course. I owe much of my knowledge to his ideas. This time we're going to load the end plate, but we're going to load the end plate more posteriorly. Slide back a bit. Okay. All right. Can I go a little higher? Yeah. Posterior loading. And you can throw some traction in as well, or traction with bias. Then I let it down, make sure everything's okay. Can I do it again? Yep. A little higher? Mm-hmm. Say when. Some people's range of motion is really great and some people not. I don't think it means that much. It's interesting, the gymnasts and dancers that I have with low back pain, even though their legs can go way back, that seems to be the area they're blocked. When I bring their legs as far back as they can go, they seem to respond. I don't know how someone's going to respond though until I do the tests. That's why I do these tests. These procedures on the back are incredible. Most of your back problems are going to get better from this. Once, and then if you think about the morphology, the lecture in the beginning, once you can correct things in the blood flow in the end plate or the intervertebral foramen or the shape of the vertebrae themselves, that's the time to do the muscle techniques. That's the time to do the muscle lengthening. That's the fast twitch incorporation and the inhibited groups, time to strengthen those.